There we are. And Dr. Moore, I will turn it over to you.
Well, thank you, Mayor and Deputy Mayor and councillors, and through you, the community. I very much appreciate the opportunity to speak with you tonight and hopefully answer any questions that you may have about this rapidly changing environment we're now living in. And I do want to acknowledge the sacrifices that many in our community have made for social isolation and the economic sacrifices they've made. But I think our community is doing well from a health vantage point, that we've been able to control and limit the spread of COVID, and we must continue to do that work. We all must remain vigilant, and I have to thank everyone in the community for having been so reasonable and prudent and adhering to the new normal. With your permission, I can go over the background of COVID, some of the actions that your local public health agency has taken in partnership with you and our local hospital and L&A paramedics. And then we can discuss the new recovery plan that was just released today by the ministry and the Premier. And I'm happy to take any questions. Next slide, Deb.
Thank you.
So the background, this is a new infection. We've never seen it before. None of us have immunity to it. On average, if you're exposed to it, you start to develop symptoms around 5 to 7 days later, and you may develop a fever and or a cough and or increased difficulty breathing. There are other symptoms associated as well, such as a sore throat or laryngitis, or if you're elderly, you may have an exacerbation of your underlying diseases. So if you have heart failure, your heart failure may get worse, or if you have lung disease, your lung disease may get worse. And on average, if someone gets that infection, they are infectious roughly a day before their symptoms develop. And by around day 14, they're no longer infectious to anyone else. So that's why we ask anyone that's come in contact with someone who's diagnosed with COVID-19 to isolate themselves for 14 full days, because after that period of time, they shouldn't be infectious to anyone else. Next slide. So we, your local public health agency, practices response to pandemic. And this summer, we had brought all our paramedics, acute care partners together and had worked through how to respond to a severe influenza season, a mild season, and or a new pathogen. And a lot of that work that we had done in the summer, bringing partners together, has paid off. We've also met with all of our primary care partners in early March and prepared them and their offices how to respond to this. And then we set up our assessment centers, and we have an assessment center at Lennox and Addington Community General Hospital that's really working very well to rapidly assess patients, to test them, and to follow up with them if needed. And we're partnering with them on that work. Next slide. So most major areas of the globe have gone through severe epidemics, like in New York and or Washington State and or Northern Italy or Iran or China, where they have a sudden rise in patients. And I think that's what our community was most concerned with, our province was most concerned with, and overwhelming the health system. Well, I'm happy to say our first wave of infection peaked on around April 1st, where we had around 8 cases in one day. That was our peak. And over a total of around 50 people got infected. And those were mainly individuals that were returning from outside of Canada, and snowbirds returning or returning travelers. And luckily, through combined efforts of our healthcare providers and public health and our community, we've been able to limit the spread. And our hope is that we can just have small undulations or small waves of activity, but never a sudden wave like many countries are experiencing, or large cities in North America. Next slide. And it's taken really an entire community to respond to this. And all of these partners in our chain of protection for KFL&A have really worked hard to limit the spread of this infection, whether it's our school boards, our colleges, our long-term care facilities, retirement homes, primary care. We've worked very closely with Quinte Detention Center, with our federal corrections facilities in Bath, and also with our healthcare partners and families and communities and agencies. And it takes a community to respond and protect our community from this new pathogen. And I have to highlight the significant work that every one of these agencies and partners has done to limit the spread, and the sacrifices that many have made in our community. Next slide. So we went into an incident management system, somewhat like yourselves, to respond to this, and have been meeting 3 times a week ever since, and have had to try to a social media campaign to increase awareness of this illness in our community. And we've been quite active in many domains to try to make people understand the ramifications of this infection and the necessity of adhering to social and physical distancing. Next slide. So our current dashboard, you can see it on the KFL&A public health website. We've had a total of 59 cases in our community, 56 of which have recovered. So we only have 3 active cases in our community, one of which was a healthcare worker who worked outside of KFL&A and acquired the infection outside, but their address is here. So that's why we count individuals by their address. We've had only 6 people that needed to be hospitalized. We've had no deaths, and luckily no significant outbreaks in our long-term care facilities or our corrections facilities, which we're very concerned about the risk in those environments. So that's to date, and we're working diligently with all partners to prevent further spread in the community. But as you can see from this graph, the worst is over with around April 1st, and we're now just getting small number of cases. Often, if they've traveled within the province, they may risk bringing the infection back. But we're somewhat in a bubble in southeastern Ontario, where we have very low community spread and very good community. As you can see, multiple countries are experiencing much higher rates, or cities. So New York City, I think, is still on a trajectory to increase the number of cases. Italy is starting to flatten out, and this is what we mean by flattening out the curve, where you want slow growth over time, very little growth. And British Columbia just recently had another increase in cases. Ontario is starting to flatten out, but we still have significant activity in southwestern Ontario, Toronto and Ottawa, but certainly in southeastern Ontario, so Leeds, Grenville, Lanark here, and Hastings, Prince Edward, we have been flat with no growth for quite a while. Next slide. Our assessment center, I have to thank LACGH Hospital. They've, Kim Morrison, Mr. Koviduck, they've done wonderful work to be able to allow patients to be assessed and then treated and to protect their hospital against any spread of COVID-19 within the hospital sector. They've had a brilliant strategy. And together we've tested 2,261 patients and have had a high testing rate for our region. And the percentage of all of our tests that were positive, we reached a peak early on in the epidemic where around 6% of our tests were positive, and now we're down to around 2% of the tests are positive. So that's a very low rate of positivity. The province on average today is around 7% positive for all tests. Next slide. And we've also worked very closely with all of our primary care partners, and we've got a great group of primary care physicians in Loyalist Township and in L&A who have helped us in early identification of cases, early testing, and also provide care in our long-term care facilities in Loyalist. Next slide. In the acute care, originally around 2 weeks ago, we had around 200 bed capacity at Kingston Health Sciences Centre and around 30 ventilators that were open and ready in case we had a surge. Luckily, due to our community's efforts, we haven't had a surge in health system need. And so they're using the beds now for different purposes. We only have 68 available and 8 ventilators. And Lennox and Addington Community General Hospital at one point had 12 open beds and 2 open ventilators. But that capacity is being lost now. They're not allowing us to transfer patients back to long-term care facilities if they had to go to the hospital. And hopefully that will open up soon to allow the transfers. They wanted to give the long-term care facilities just a bit of a break, given all the pressure they've been under recently. Next slide. I also have to thank, we've had great relationships with both Frontenac paramedics and L&A paramedics. And our L&A paramedics are starting to get trained in how to do the nose swab for the virus, and will be partners if we have major outbreaks in swabbing, and have been transporting patients between facilities with full personal protective equipment, and been great partners in protecting the health of the community throughout this. And next slide. Our long-term care, the 4 long-term care facilities within Lennox and Addington will be part of a new swabbing initiative. So we're going to be testing everyone who works in those facilities, as well as all patients. And we're starting in L&A, and then we're going to move to Kingston and Frontenac. And we've just been lucky. We've been inspecting these facilities with our public health inspectors and our public health nurses since early March and late February, and have been going into the facilities every week to support them, to provide education and guidance on infection prevention and control. And it seems to have worked, having that strong partnerships with all of these facilities. Next slide. So our main job with our long-term care facilities will be helping them with outbreak management. And we've been practicing with them. We've partnered with them on testing. Our long-term care facilities in KFL&A have one of the higher testing rates, even though we've not had any outbreaks. Around 20% of all patients in our long-term care facilities have already had a test. Clearly, they've been negative. And so I'm very happy with the work that they've been doing in their facilities. We have one of the highest testing rates outside of outbreaks. This slide, no, you can stick on this one. This is just to illustrate that long-term care facilities are an at-risk part of our community due to the nature that the individuals are there. They're often frail. They're there for a medical reason. And the cumulative number of residents that have had illness is, I think, Deb, we're just covering that number, 1533, and around 800 staff have tested positive. And sadly, on April 18th, they've also had 300 deaths in these facilities. And hence the reason we started in late February and March working to prevent infection getting into these facilities. And then I'm happy with the partnerships we've had locally. Next slide. We've also partnered with all of our institutions. So we have around 2,400 federal inmates in Kingston, Frontenac, Lennox, and Addington, which is if an infection gets into those environments, I think we've heard the news in New York and in other jurisdictions in Canada, the infection can spread quite rapidly. So we've had great partnerships to improve their prevention strategies. And we continue to consult with them both at the Quinte Detention Center as well as the federal corrections. Next slide. And we're also providing consultation on the emergency childcare centers for healthcare workers for screening of children and staff, for case and contact management. And luckily, because we have a low incident rate in our community, these have been working quite well with no major issues to date. Next slide. And as well, our colleges and universities were good partners. Queen's and St. Lawrence College closed classes quite quickly in consultation with us, and then moved to electronic learning. And I do believe in September, they will continue with that. They won't be bringing students back to our communities, although that's an ongoing discussion. The school boards, the schools have been continued to close until May 31st. And we've also consulted with our military base in Kingston, who've been great partners as well. And we've partnered with the city of Kingston that provide, they used to have a shelter that housed around 40 people, but they were in bunk beds in one major room. We now have separate facilities for anyone that has an acute respiratory infection, individual rooms with staff that have full protective equipment, and another shelter that again has individual rooms, but is for those that don't have any respiratory infection. But we haven't had any detection of infection in that vulnerable population, and that's a resource that anyone in our area can use. Next slide. Planning ahead, the main things that are going to slow this down, since none of us have immunity, is giving immunity to someone through either an immunization and or having an effective treatment. And I'm going to be upfront, we don't have either as of yet. And there's various timelines to have a safe and effective vaccine in our hands. That's probably 18 months away because it's going to take study. We don't want to ever provide a vaccine without good knowledge of its effect profile. And that it's both safe and effective. And that's going to need a good body of evidence and then a production of it to be able to be given to any individuals in our community. So until that time, we're going to have the new normal. And next slide. The ministry today, the Premier and the Ministry of Health discussed a strategy to open up the economy. They basically followed the WHO guidelines, which are these 6. So transmission's controlled, and I think transmission is controlled in our region, that public health has the capacity to follow up any positive cases day by day by day when we're operating 7 days a week on case management and contact follow-up. The health system, though, is still short on personal protective equipment. It's still short on ventilators. It's still short on medications, and those issues need to be fixed. We've worked well to minimize the risk in our vulnerable settings, which is great in terms of that chain of protection I discussed. If any businesses are to open up, they have to look at how to reduce infection. So social and physical distancing, masking, hand washing within their jurisdiction to bring their businesses back. Risk of imported cases have to be managed. So borders, the southern border with the United States will have to be maintained closed because they are going through a much higher epidemic risk than we are at present. International borders may be able to be opened up dependent on the risk of infection. And then we need our community engaged to tell us that they're okay with us going through a step, phased, slow, and reasonable approach to reopening the economy that won't lead to the unintended consequences of increased disease spread or infection in our community. Next slide. So we have written a document that we'd like to share with you to get your feedback on a phased approach to opening the economy based on local data and local surveillance. And we'd be seeking your feedback on that. But again, the major issues that I think are still limiting us are the personal protective equipment of workers. We don't have more than a week's supply for most of the garments. And our testing capacity is still getting stretched to the limit in Ontario, and we need that fixed before we can open the economy up. Next slide. So we have to continue the new normal of staying at home, hand hygiene, covering your cough. If you can't maintain a 2-meter distance from someone, you should be wearing a face mask in public, not a medical mask if you don't work in a healthcare system. We need to continue to protect our vulnerables in our community. And I have to salute our community and your leadership in our community with the declaration of emergency, that everyone's actions are making a difference. And we have to stay the course. We will get through this. We must be consistent and persistent in our approach, though, and always be vigilant. And we will get through this. And I'm happy to take questions. Sorry if I went over.
That's absolutely fine, Doctor. And I thank you very much for your presentation. I turn to Council. Do you have any questions for Dr. Moore at this time? Ben?
Councillor Porter here. I do.
I'll start with Councillor Porter.
Thank you very much, Dr. Moore. Your presentation was very good and informative, and I appreciate you taking the time out to present that. Just a clarification, the number of cases in KFL&A, that is the number of cases that we know of from testing, but we don't really know how many actual cases. Is that a fair statement?
I think that's fair. We have been very aggressive with testing because we had testing available, both because Kingston Public Health Ontario has a lab and Kingston Health Sciences Centre developed testing early on. We were so fortunate to have very good testing capacity. I'd say much better than any other local public health agency of our size. So we were able to test almost everybody that we were concerned about early on, even early on. So we could have missed some early that we just said to isolate, but the vast majority, when they couldn't, they couldn't come to an assessment center, I would go to apartment buildings in those very early days when family physicians were a little nervous about testing to ensure that we were testing every individual. So our counts aren't bad, but we probably did miss some instances. Great question.
If I may follow up with that, I know that there was recommendations that if there were just mild symptoms that they didn't necessarily need to go to a testing center or need to attend a hospital, and that was the basis for my question, and that
I'm happy to
go ahead, sorry.
I'm happy to follow up on that as well. You're absolutely right there. We were only allowed initially to swab those that had a fever and or a cough and or increased shortness of breath. Around 2 weeks ago, when the government's testing capacity improved, we were allowed to test for those that had minor symptoms. So as I said, the sore throat, the laryngitis, some of the runny nose, fatigue, change in smell, change in taste. So you're absolutely right. Only recently have we been able to expand it to those that had sort of atypical or minor symptoms.
Okay. And then you said in your presentation that no one has immunity to this. So are you saying that it's, if you've had it, it doesn't mean you're immune? Is that what your statement is, or is the science still out on that?
I misquoted. I should have said very few of us, except the 59 that have been confirmed test, have immunity. So of 200,000 people in KFL&A, really only 59. So it's 99.9% of us don't have immunity to this virus.
Unless you've had it and just not been tested, or feel that you've had it and just not been tested. I'm just speaking from my own experiences that early in February, I had all the symptoms of something very similar, very unique, put it that way. And that was before we knew what was going on. So, and I suspect that probably I was not alone in that. But that was just a comment there.
Well, we may have in our tool chest soon a validated test called a serology test, which will be a blood test. And it will look at whether your body's been exposed in the past and whether you've generated an antibody. So you're right, that's a new tool that we may have to help those that could have been potentially infected early on, but we didn't have a test, or we weren't testing minor symptoms. So we may do what's sort of a seroprevalence study, where we ask individuals that think they had the symptoms to give a sample of blood, and we'll test to see if you've developed immunity. So the 59 people that we've absolutely confirmed they were exposed, that number may multiply if we can do the serology testing, but we have to wait till we get a reliable one and it's validated.
And when do you think that will happen? Do you have a timeline for that?
The government of Canada would be the ones that would license it, and they're looking at the sensitivity of the test and how well it would work and how reliable it is. So they're still assessing it. What they did in the United States is they let anyone use their serology tests, and we really don't know how valid or reliable they are. So there's a whole mix of science in the United States that we can't validate anymore. So we're waiting patiently to get the right tool into the right hands.
Okay, thank you.
Great questions.
Are there any other questions for Dr. Moore at this time? Councillor Townand.
Just a comment first, Dr. Moore, to thank you for your leadership in our region. I think I can certainly probably speak for my colleagues and other municipal partners how grateful we are to have you as our medical officer of health. And I think we've as you pointed out, demonstrated the importance of everybody coming together in a collaborative effort to follow public health advice to be able to do what we need to do. So on that basis, can you comment on your own personal advice the federal government is receiving from the Chief Public Health Officer, and speak to the importance of a collaborative Team Canada approach to this pandemic across all levels of government and regions?
Well, that's a very good question, and thank you very much for your comments. It really is not me. We have a very good agency, and we have great collaborators, and some of the collaborators are on this call right now. We've had great partnerships throughout with our leadership in KFL&A and our councils, and we can't do it without you. So thank you as well. Absolutely has to be collaboration, coordination, and effective communication at the federal level, provincial level, local level. And without that, we won't succeed. And we had a lot of learning that was done initially about when to close borders and open borders and control travel. Those were tough decisions at the time, and they were the right decisions. Certainly, we would have loved them earlier, and more effective quarantining at the federal level. These will be lessons learned, but we're in actually a good position relative to many other countries. I think once we evaluate our actions, we will learn, we'll be better prepared for the next time. And we must continue to work effectively together. I'm very happy that the comments that our Premier is making, working with the federal colleagues and being collaborative and communicating effectively across all barriers, all parties, and all levels of government. I mean, I'm frankly, I was surprised and pleasantly so that how effective federal, provincial, and local jurisdictions are working all together to fight this infection.
Thank you. Anyone else have a question or comment for Dr. Moore? Councillor Parks.
Thank you. Through your worship, Dr. Moore, I was just wondering about the vaccines that they're working on. Would that be specific to the COVID-19? My understanding with these coronaviruses, they jump species to species, and they are very similar in nature based on what happened with SARS. But is the vaccine that they're looking at specific to the COVID-19, or would that be kind of a general vaccination that would happen?
Great question. Thank you so much. And it would be very specific to this COVID-19 pathogen, and it would only use if you think of it as a crown with the little dots around the circle, you'd take the little dots where there's spike proteins, and that's what our body reacts to. You take those spike proteins from that particular virus, and you'd mix it up with an additive agent, and that's what gets injected into the arms. So that it would be very specific. So if the virus changes or mutates, we would have to modify what spike protein we use. And it's remained relatively stable to date, even though it's a new virus. It hasn't mutated significantly as compared to influenza, which is very promiscuous and changes rapidly and shares its RNA around. So we will need one vaccine for influenza, which changes seasonally, and one for COVID going forward. And most likely this virus will eventually become one of our winter viruses that causes illness. And hopefully down the road, we can combine them into one injection, but initially they'd be separate.
Thank you, Dr. Moore. Anyone else have a question or comment for the doctor at this time? Seeing none. Again, Dr. Moore, I reiterated my comments from previously. Your team with public health has done an absolutely amazing job, and we really appreciate all the efforts that you personally and all of your team have put into this. Hopefully we keep working together and keep this curve as flat as possible, plank it, whatever term you want to use, and that we yes, we will have people that will get sick, but hopefully they'll get sick over a slow enough period that our healthcare system can manage it. So thank you very much for your efforts on this. Infection control is your specialty, and we appreciate it.
Well, thank you for the opportunity to speak with you today. It's been wonderful.
Thank you. We'll look to council for a motion to receive the presentation from Dr. Moore. Councillor Townand, seconded by Councillor Gordon. Any comments? Councillor Townand, go ahead.
Just to receive the delegation with the utmost thanks and gratitude.
And Councillor Gordon, second comment. Anyone else? I'll call the question. All those in favor? Any opposed? Motion is carried. Thank you very much, Dr. Moore.
We'll convey your thoughts to our staff. Thank you again.
Thank you.